Good afternoon and welcome to the Drexel Library Spring ScholarSip. For those who don't know me, I'm Danita Nitetsky, Dean of Libraries, and I want to really thank you for joining us today. It's hard to believe that we're wrapping up the 11th year of ScholarSip today. It feels like we hosted our very first Food for Thought event just a few days ago. So we launched the event series back in 2012 as part of the library's strategic goal to help build cross-disciplinary community at Drexel and to connect our dragons to scholarship. Each quarter, the event brings together colleagues from all colleges, schools, and many administrative departments for food for thought, discussions on interdisciplinary research conducted at the university, and for a toast to the end of the academic term. So this year, turn this thing off, I thought it was. We decided to experiment with a completely virtual format, something we started in 2020 due to COVID-19 and the shutdowns in that period. The pandemic has shown us that virtual events are not only easier to plan, but they also do reach a wider audience, allowing us to make connections with more members of the Drexel community in Philadelphia and even across the country and the world for some of our events. But several of you have asked us when we plan to return to in-person events again. And I myself do miss the personal connections one can make when meeting in person and sharing refreshments. We are looking at returning to in-person community building events next year. So please stay tuned for more details and tell us what you think about the event format to help us with our planning. So regardless, I hope you will continue to join us wherever we might end up meeting. So in the meantime, we once again mailed virtual swag bags to our attendees who registered far enough in advance. We hope these goodie bags help you feel connected to each other in some small way. Please do enjoy your snacks and the ScholarSip tea blend that we chose for today's session. So now, before I introduce today's thought provoker, let me tell you about this year's theme. This year, we decided to feature Drexel research related to climate change and sustainability. A few years ago, the university made a commitment to fighting climate change, and there is so much important and diverse research in this area at Drexel and beyond. We are thrilled to shed a little bit of a light on some of this work and to connect our faculty, staff, and students across disciplines with just a taste from the menu of the Drexel research being done in this area. So for this year, we have heard from Westphal Professor Ben Kalina, who kicked off the series in December with a discussion about his work to create documentaries about the global climate crises. In March, Professor Carolyn Schauer led a discussion on her work to make plastic alternatives from food wastes. And now I'm pleased to say a few words of introduction about today's speaker, our final Food for Thought presenter for the 2022-2023 academic year. Drexel Professor Nathalie May, who will wrap up the series with a discussion on climate change and primary health care. Born and raised in Port-au-Prince in Haiti by her maternal grandmother, Dr. May came to the United States as a child when her grandmother was diagnosed with breast cancer. Watching a loved one suffer and eventually succumb to breast cancer at a time when there were only a few unpromising treatments and virtually no palliative care inspired Dr. May to pursue a medical career. She attended Princeton University and went on to medical school at the University of Pennsylvania, where she also completed her internship and residency in internal medicine. So Dr. May joined the faculty of Drexel University College of Medicine in 2000 and is an associate professor and the medical director of the flagship internal medicine practice at Drexel. She also maintains a busy medical practice where she prides herself on delivering excellent care to her patients while practicing preventive evidence-based medicine. So before I turn the Zoom controls over to Dr. May, let us continue our ScholarSip tradition with a virtual toast to the end of the term. So please raise your tea or drinks or whatever you brought with you. And let us remember that this is the moment when the students are probably at most stress. I walked in here and they're sitting out there studying cramming in those last facts and those last moments of things. So be kind if you're ones that have to grade papers, and let's just get these dragons through this year as well. So here to the spring 2023 term.
You're here.
So thank you again for joining us today, Natalie, and I'll pass the Zoom controls over to you.
Thank you. Thank you, everyone, for showing up. We are delighted to be here. Our project is on climate change and the impact of climate change on primary care utilization in Philadelphia. The way that we have things set up, my team is all here, and we will have 3 different speakers. And I will ask each of them to introduce themselves now, and then we'll start the presentation with Dr. Williard. There'll be plenty of time for question and answers, and we look forward to hearing your thoughts about our project. So my first speaker will be Dr. Adrienne Williard. Adrienne, do you mind introducing yourself?
Hi, everybody. Thanks for having us. I am Adrienne Williard. I'm a general internist here at Drexel. I'm in the same internal medicine practice that Dr. May and Dr. Fitzpatrick are in. I've been here with Drexel for over a decade now, which is wild because time flies by. And outside of patient care, which is about half of my life, the other half I get to help educate our amazing medical students on clinical skills in the preclinical years, in particular with like the fun stuff that's taking from books to the bedside, helping them with that transition. So we're excited to talk to you about our project.
Thank you, Dr. Williard. Dr. Fitzpatrick, do you mind introducing yourself?
Sure. Hi, I'm Janet Fitzpatrick. As you've already heard, I'm a general internist as well, and in the same practice with Dr. May and Dr. Williard. I am a Hahnemann alum, graduate of 1995, and also did residency and chief residency at Hahnemann, and I've been an attending now for 24 years with Hahnemann and now Drexel.
Thank you, Dr. Fitzpatrick. Janelle Edwards is also a member of our team. Janelle, can you introduce yourself?
Hi, I'm Janelle Edwards, and I am a third-year doctoral candidate in the Environmental and Occupational Health program at Dornsife School of Public Health, and I work under the mentorship of Professor Leah Shinazi, who is an assistant professor also in Environmental and Occupational Health, and she also helped with guiding me on the statistical analysis I'll be presenting on. And my overall research interests include climate vulnerability, emergency preparedness, environmental justice, and health disparities. So I was really, really happy to be a part of this project. And it allowed me to get more insight on the clinical insight of research.
Thank you, Janelle. Janet Matthews is also another member of our team. Janet?
Hi, everyone. I'm Janet Matthews. I am working with this wonderful team on the climate change. I work in the College of Medicine in the Senior Vice Dean for Research office. I am a nurse by background. I was a nurse at Hahnemann for almost 20 years and then moved into the research sector. And then I feel like I am also help with the collaboration of bringing the data to the bedside and working kind of both between the data and the clinical aspect, bringing the team together with those aspects. So very excited to be here today and answer any questions.
Thank you, Janet. Without further ado, I'm going to ask Dr. Williard to start our presentation, so we'll have plenty of time to interact. Thank you.
Wonderful. Okay, so just to give us a little bit of background for how we came upon the idea of this project, talking about climate change, it is predicted that the Earth's average temperature is going to increase by 3.5 to 10.5 degrees Fahrenheit by the end of the 21st century. So, you know, within 77 years, we're going to be here, which, you know, may not be in our lifetime, but certainly the lifetimes of our children and our grandchildren. And the impact of this, we already can feel it locally. And if you look at some of the data from our own Philadelphia, December of 2021 was the second warmest December on record. And the average summer temperature has increased by 3.5 degrees since 1970. So we are already feeling these extremes of temperature. And as we noted this as a group of primary care physicians, we asked ourselves, well, what is this impact on human health, on the lives of our patients? So if you think about these extremes of temperatures, these heat waves, what are they leading to? Just the extremes of temperature themselves, and then also the subsequent changes in climate with increased precipitation and increased flooding. This picture down here is actually right after Hurricane Ida in 2021, where this is literally, you can see this from the windows of our office practice. So it is in our backyard. It is happening to our patients. It's happening to our neighborhood, to the people who we care for. And when we think about diseases, what could this possibly impact specifically? So we envision this, although maybe not studied, that it's going to impact patients with heart failure, asthma and COPD, breathing conditions. The quality of the air makes it harder to breathe. Chronic kidney disease, folks who really, their volume of their body, the amount of fluid they're retaining is very sensitive to these changes in climate, and even just dementia and mental health itself impacted by this. And who might be at increased risk? We're thinking about our lower income communities that we help care for. And then in particular, patients living in flood prone areas within the city, which are very close by to where we are. And it is predicted that an additional 250,000 deaths per year could occur due to these changes in the years between 2030 and 2050. So we're asking ourselves, if we don't do something to mitigate this and make a change, the end game, the amount of lives that are impacted may be even greater than that. So as we thought about this, we realized that this really isn't something that's been looked at in great detail. And what we wanted to aim to improve were the gaps in knowledge, looking at the impact of climate change on primary care health utilization in the neighborhoods in which it may be impacted by these changes. Secondly, which populations have the highest primary care needs in the face of climate change? And then our research is really going to look at a population of patients in Philadelphia where we have a subset of vulnerable patients, and they really may need increased help from us to get them through and safely take care of their diseases. So our aim was to examine the impact of heat waves and extremely cold conditions on primary care utilization patterns overall, and looking then at the socially and environmentally vulnerable Philadelphia neighborhoods. And our hypothesis really was that these extreme weather events will be associated with the higher rates of what we call no-shows and cancellation rates at primary care practices. In particular, looking at, we think that the elderly and then people living in socially and environmentally vulnerable neighborhoods will be impacted. So we feel like we've observed that patients don't come to their visits when there's extremes in weather. We didn't have any data to back that with, but we were like, this seems like a very reasonable thing that we've observed, but let's try and prove it. Let's see what the data can add to that conversation. So with that in mind, we gathered some data, and I think Janelle's now going to explain to you guys the process by which we looked in to explore this very question.
Yes, thank you. So I wanted to walk you through a brief overview of the methodology of this project. So first and foremost, we downloaded day-specific data on the maximum daily temperature, daily snowfall, daily precipitation that was recorded by a weather monitor at the Philadelphia International Airport. And then we linked in this weather data to electronic health records from one of the Drexel University affiliated primary care and family medicine practices. And to be eligible for inclusion, patients had to be over the age of 18 between the years of 2009 and 2019. And we defined cases as days between 2009 to 2019, where a patient was reported to have canceled their appointment without any attempt to reschedule for a later time, or if a patient did not come into their appointment, resulting in a no-show. And then we calculated the number of missed appointments over the total number of appointments for each day of the study to get the overall rate of missed appointments. And then we performed a time-stratified case crossover design to assess association between missed appointments and temperature. And we modeled temperature in two distinct ways for this analysis. The first way is that temperature was modeled continuously, and we then also assessed the role of extreme temperatures on missed appointments by then categorizing temperatures. Specifically, extreme cold temperatures was when temperatures were less than or equal to 30 degrees. And extreme hot temperatures was when temperatures were equal to or more than 95 degrees. And we made these categorical distinctions based on the cold blue and cold red weather alerts already defined by the Philadelphia Department of Public Health. And lastly, we then adjusted models for holiday status and other time-varying weather variables that may confound associations, such as precipitation and snow. And if you could click the next slide, Thank you. And so this figure illustrates the overall relationship between temperature modeled continuously and the odds of missed appointments across the study period on the day of the event, so day lag 0, and the cumulative lag effect on day 5, using 67 degrees Fahrenheit as a referent, which was the median temperature across the whole study period. And in this figure, you can see as temperatures move away from the referent in both a positive and negative direction, the odds of missed appointments increases, which warrants a greater exploration of associations at these extreme temperatures. Thank you. And so for transparency, we included a slide that shows the number of cases per weather category. So during 67-degree days, which was the referent temperature for this analysis, there were 4,672 cases. During extreme cold temperatures, there were 7,966 cases. During extreme hot temperatures, there were 7,365 cases. And lastly, because we really wanted to observe if there was a dose dependence response, we categorized moderate temperatures as temperatures that did not fall in either of these extremes. And because this included such a wide range of temperatures, there were over 300,000 cases associated with this category. Next slide, please. Okay, so here are the results that reflect the odds ratio and 95 confidence intervals of associations between missed appointments and the different weather categories based on the daily maximum temperature across 2009 and 2019. So model 1 is showing just accrued associations. Model 2 is showing adjustment for holidays. And model 3 is showing further adjustment for snow and precipitation. And the bolded odds ratios illustrate significance. So turning your attention to the fully adjusted models in model 3, so that last column, after adjustment for holiday status, precipitation, and snow, the odds of missing an appointment during extreme cold temperatures was 1.09 times the odds of missing an appointment when temperatures were just at 67 degrees. And the odds of missing an appointment during extreme hot temperatures was 1.0 times the odds of missing an appointment when the temperature was just 67 degrees. In addition, patients that had appointments scheduled during non-extreme temperatures also had an increased odds of missing their appointment compared to the referent, though the magnitude of the estimate was much smaller than in these extreme temperature categories.
All right, so I'd like to take over from here. So, as internists, we are not looking at preventing or slowing down climate change. We leave that to other people who have different skills than us. But our question was, what can we do to mitigate the effects of climate change for our patients? And so, things that we can do are to plan ahead, listening to weather forecasts, understanding what is coming any given day or any given week, considering vulnerable populations, those with chronic illness, the elderly, offering telemedicine visits. So just like we're here today doing Zoom, which started because of the pandemic and not being able to be in person, perhaps if our patients can't come to us, we can reach out to them with telemedicine, make sure that they are still getting medical advice. We can assess other options for things like, pharmacy prescription delivery. If the patients can't get to their medicines, can we get the medicines to the patients? So planning ahead, utilizing physician care extenders, people like nurse practitioners and nurses and physicians assistants in our office to reach out to patients and, help to better coordinate care. There are other potential things that can be done in terms of outreach options. Things like considering temporary satellite or pop-up clinics in vulnerable neighborhoods. Again, when patients can't get to us, perhaps we can get to the patients. We certainly can't open up offices throughout the city. So the concept of that pop-up site, something that's temporary in a time of need. We can think about partnering with community centers for the elderly same kind of concept where we don't have an office someplace, but if there is a senior center or a place that is within a neighborhood that patients can get to, even if they can't get to us in Center City, perhaps we could get to them. We can also coordinate with other partners, home healthcare nurses, to perhaps arrange home healthcare visits where vulnerable populations are and they can't come to us. So again, just getting out and doing some community outreach, in light of extremes of weather could make a big difference for our patients and for their overall health. All right, next slide, please. All right, and so what are our next steps? We have just begun this process of looking at the data and researching it and actually putting numbers to things that we're thinking. Moving forward, some things that we have kind of in the pipeline that we want to look at or are more specifically assessing the impact of specific chronic diseases on those missed appointments. So things like COPD and asthma that have been talked about, heart disease, chronic kidney disease, mental health issues, assessing more specifically the impact of precipitation. So specifically rain or icy days or, snow in particular for those cold weather days when patients, even if they could come out and it was cold, they're not going to come out if it snows. And then also more specifically assessing the impact of very specific vulnerable populations, breaking down the data and looking at it by age, by gender, by race, by other socioeconomic status, such as using zip codes to look for more vulnerable populations. So there's a lot that we'd like to look at moving forward in the future.
Thank you. Adrienne, you can take down the PowerPoint. So that concludes the presentation part of our research. We hope that you have a better understanding of what we've been doing, and we invite you to ask us questions and get engaged, and we're happy to answer.
I guess one question would be what resources are needed to, make some of this possible? What would it take so that, I happen to know you don't have a huge amount of staff with extra time on their hands. What sort of resources would be needed to be able to, give people an advanced heads up or something like that, look at the forecast and things like that?
I think that's a great question, Dr. Hanau. Thank you for asking it. I think several things. One, we know that the budget is an issue, but we do have forecasts and we do have all these alerts that we get on our phones. And I'll give a specific example. Last week, when the air quality was really poor, one of the things that we were able to do once we got the alert is reach out to patients who thought they might not be able to come because the air quality was so bad, specifically patients with respiratory issues. And instead of saying, we're going to cancel your appointment since you can't come, we offered to convert their appointment to telemedicine. One of the big things we will need is above our pay grade, but it's a political issue, is to keep the ability to have telemedicine reimbursed for primary care visits.
Yeah.
I think that's something that we know during COVID is helpful, and I think it's something that will help all our vulnerable population to continue to have that.
I just want to add one comment to that as well. I agree the resources can be slim at times, but when we are actually calling to cancel the appointments, something as simple as while you actually have the patient, make the rescheduled appointment right then and there. Don't just cancel and then say, well, we'll call you back. While you have the subjects engaged, something little like that with the awareness of staff and for the providers, for the extended providers, and even the patients, get to know them and ask them questions. Like I've learned over the years that when you have a patient that, may have asthma, but when it rains, his knee hurts and he can't get up out of bed in the morning. So you know what? You might have an afternoon appointment that might be able to, because he's a little slower at getting out. Those little things make a difference, and just more the awareness and having the patients engaged when you have them on the phone when they're going to cancel the appointment. I think the results of this research, just really bringing that to the forefront, to the practice, will help, I think, with all of the patients and getting that rescheduled, with the hope of keeping that telemedicine obviously would be, you know, a priority, but these little things that we can do will help too.
That's a great point. Thank you.
So I have a couple of questions. This has really been interesting. It's one of those points I think that we, should I go ahead? Is there somebody else?
We can hear you, Ramesh.
Okay. You know, so one of those things that you kind of think about, but I mean, it's nice to have numbers to it. So I guess my question is that in terms of, I have a couple of different questions. One, going, you know, starting off on the bottom, I mean, the most recent point with respect to telemedicine that Janet talked about. It's also the population, the population that you're talking about is probably likely to be the population that has less access to resources for telemedicine. Am I wrong in that, or is that a possible? I mean, because you need to have certain infrastructure to be able to do telemedicine, right? And it's a question of using and a question of access to those resources that might be a problem for these patients. Am I correct in that, or is that not really a problem to offer them the telemedicine option?
So
I don't, yeah, go ahead.
Okay, so, you know, I completely agree with you that there are elderly patients that have technology issues. I would say that many of our patients do have children or people that help them when they do need to do telemedicine visits now. And so, you know, I do think that those are people that would help. We do see that a lot of our patients are using our patient portal and are becoming more familiar with electronic devices. And, you know, this can be done on a phone, this can be done on a computer. And I think the vast majority of our patients are getting there or have friends or family that can help them.
Okay. And the other question that I had was, when you say these are missed appointments, I mean, this is, do you anticipate that with the poor weather coming up, that there is a population that is likely to cancel their appointment, and so you're proactive in contacting them? Or is it that there's a certain appointment at a time on that day with poor weather and they just are no show? That part I didn't understand exactly how you, was there no show and after the fact observation that such and such a patient was supposed to come on this day and they didn't come? Is that how you did that, or were you proactive in identifying that and saying, okay, you can't come today, can we reschedule you?
So we're looking at data from 2009 to 2019. So this isn't data where we've been proactively looking. This is a retrospective analysis.
Oh, I missed that part, sorry. Yep.
Connie, you have a question?
Yeah, I just had a question. I was wondering, in the planning or consideration thing, if you called patients at those times, these are also patients that would likely be at higher risk for having problems in their homes during these periods of low temperature or high temperature because of, you know, potential inadequate heat or air conditioning. So, you know, this country has a difficult time, you know, meshing public health issues and primary care, but that's something else that you could, you know, ask about. Maybe, you know, do they have access to air conditioning? Do they have access to heat?
One of the things that we're looking at doing next is looking at the populations in relation to the weather. Are there different different neighborhoods that get flooded? And then let's look at our patient population with a certain chronic illness that seems to maybe deteriorate quicker with, a cold or, breathing, that kind of a thing. And then the primary care team can be more proactive, especially when they're calling in. So when they call in and say, oh, I have to cancel because of weather, then they could have trained staff to say, oh, you have a diagnosis of a high risk, living in a high risk neighborhood because of this. Let's do something about it before we get you off the phone. Whether it's just, hey, let's just do a quick med reconciliation and make sure you're doing the right things, and make sure we get that appointment rescheduled if they don't have the technology, or set up that technology. So it's more like thinking like, okay, and then our next step would be to really geocode into neighborhood and connect that to weather, where those neighborhoods have higher risk.
Yeah, this sounds, it reminds me of the Costa Rican system. I mean, not completely, but a little bit, some of the things that they've gotten right. Yeah.
Doug, do you have a question?
Yeah, I want to thank the presenters for bringing all this to our attention. This is very critical, and it's not going to get better, and so we have to be prepared. So thank you for laying the groundwork and raising awareness. I just want to also ask about, your experience or plans to look at morbidity and mortality as a result of increasing frequency and severity of heat waves. And, I heard one estimate that looking at particulates alone on one of the hazardous air days from the Canadian fires, it was like smoking a pack of cigarettes a day if you were not protecting yourself. So that was kind of really upsetting, and I'm sure that's going to impact a lot of patients that you see, and not for the good.
Yeah, lots of work to be done still. Thank you for that observation. Danuta?
Yeah, so actually I wanted to pick up on what Ramesh said, but then also Doug's comment. I was thinking in the broader context of this field of research, and you're starting to get that. So to start with, what I think what triggered a question from Ramesh's comments was, what do we know about the reasons why people can or can't come to appointments? And there was also some mitigations that some of you were describing, and I thought, oh, you're going back to what I grew up with, a child that the doctor came to my home when there was a problem. Doctors used to make house calls, right? Which is a thing of long past. But what are some of the reasons really that are in the normal population, or even in particular sub populations that affect that is not necessarily only looking at climate issues, but that affect people's coming or going, and then how does the relationship of changes in weather relate? So that was one with sort of triggering. And as Doug, you were talking, the other question that sort of was coming up in my mind too is how much if we're looking at it in terms of the longevity of climate control. So what was it? Is somewhere as high as 10 degrees over almost a century that we might see. But what is the factor of the human body adjusting to these extremes? I know I've lived in very different parts of the country from before when I lived here, and then moving way down to the south. It took me about a year when I didn't feel the heat and the humidity of a place that I was living. And then from there, I went to the central Midwest, where it was darn cold again. So I grew up, and I could feel longer and deeper the changes of it. So how much of this will, when we look at the whole population, and of course there's, you're looking at extreme cases or people at risk for other reasons, but how much do we anticipate the human body as such, the organism, will be making some adjustments to the climates that might either mitigate or make different the impact of what they're doing, whether it's going to an appointment, taking their meds, any other actions in daily life that I think is really the broader area that you're looking at. How is this climate change is affecting what people's habits are and what they're going to be able to do?
So I would say, in looking at retrospective data It's very hard to tell why people didn't come to their appointments. I don't think that we captured that data, because many people just don't show up and we don't know why they didn't show up. I will say, completely separate from this study, our office will be taking a look at, from a quality standpoint, why people are canceling their appointments, and what we can do to mitigate that so that we have less no-shows in general, irrespective of climate. But I think looking at the data of the database that we have and the 10 years of data that we have, I don't know that we can adequately capture why the appointments are canceled. But we can look at those wonderful graphs that Janelle presented and see that no matter what the reason is, we definitely see those trends with the temperature changes in either direction.
But have you looked at, I'm sure others are doing research in this area too. Are there others that have, is there some emerging theory or hypothesis about what are the factors that are changing people's, reasons for people taking or not appointments, let's say? Because I think that would be sort of interesting then to see how yours fits into making progress in general, how we're going to change practice, our practice as patients and the providers in terms of how they can provide it.
I know Dr. Willard wanted to say something.
Yeah, that's a really interesting question. I think it's super complex, like anecdotally knowing all the reasons why people don't come, but still worth us doing a review to see if someone else has published something about just no-shows independent of climate. But your question about like adapting, as you opposed that proposition, I really feel like I think the human body's ability to adapt is going to be slower than the acute change on the impact of like an asthma exacerbation. So like, although the body, I think, will adapt over decades, I don't think it's going to adapt immediately for that person who has a chronic disease in the moment. I don't know if other clinicians agree or disagree with me, but I sort of feel like the pace of them is going to be very different. So I think adaptation will occur, but I don't think for the patients who we're worried about right now, the adaptation is going to happen fast enough for these like flares, so to speak.
I agree with you, Dr. Willard. I did want to address one question that Danuta asked, and it has to do with asking patients. In the past, and this is something that we're all learning, in the past, we simply marked the person as no-show or canceled, but now we're actually asking why, so that we can better tend to those patients. If it's a transportation issue, for example, now a lot of elderly patients can have a form submitted to CCT that will provide transportation. So we'll take that barrier away. Esther, you had a question.
Yeah, thank you. This, I think, perhaps relates to some of the questions that have just been asked, but I'm wondering if you've done a stratified analysis that maybe looks at age or maybe insurance type to get a sense of what the barriers might be, whether older people are perhaps less likely to venture out given weather extremes. And that's one question. The second question I have is just thinking about just the health outcomes in terms of weather extremes or severe weather, and how you might anticipate a practice managing that or mitigating some of the consequences around asthma exacerbations or COPD exacerbations, that kind of thing.
Janelle, do you want to take the first question? Because I know you did look at it. You did do the risk stratification.
Well, we're actually still trying to do all the stratifications and get them in a manuscript quality figure. But yes, that is something that we're going to look at on our next steps.
Thanks.
Does anyone want to address Esther's second question? Esther, do you want to ask it again?
Yeah, just thinking in terms of the health outcomes. I know this wasn't really one of your primary aims, but just sort of thinking about, anticipating the health risks that particularly some, elderly or more vulnerable medically complex folks will experience in extreme weather, or, how a medical practice or primary care practice might mitigate those in terms of giving people advance warning or health protective measures they might take in anticipation of, say, a heat spell or big storm.
Yeah, no, I think that's a great question. I do have an idea, but Adrienne, you raised your hand. Go ahead.
Yeah, I mean, I think, for example, last week with the poor air quality, everyone who walked through my doors that day or I spoke with, I gave them a little pep talk, but I didn't blast everyone who's on the portal, which is an option. Like if we really wanted to, and I actually don't know the percentage, Dr. May, but a large portion of our patients are on the portal. So if we in real time had a strong recommendation, we could send it to everyone on the portal. So it does then kind of circle back to some of the other great comments about those aren't on the portal, maybe higher risk, but so we couldn't really reach them. We don't have the manpower to call everyone not on the portal, but I think that using the portal to that end would be very effective. I don't know what you think,
Yeah.
Dr. May.
I agree with Dr. Williard. So we have a 73% portal activation rate, which is quite high, which is great. And the other resource that we can use is the Drexel website. We do post things there. So that's another place where, you know, if someone is just looking, I wonder what Drexel thinks of this upcoming heat wave. We could have information there, tips on how to protect yourself, stay hydrated, stay out of the heat, contact your primary care doctor, potentially convert your appointment to telemedicine and so forth.
Thanks. This is a really interesting and important project. I have to mention that in Frontiers, we actually have a little module on climate change and health impacts. And in prior years, we've actually had sessions where we've asked students to, you know, pretend they're in medical practice and think about the advice they would give their patients and even imagine advocacy that they might undertake to support their patient population. So thank you.
That's great. Thank you. That's awesome.
Oh, I'm going to enlist you next year, but I'll circle back offline.
Dr. Fitzpatrick?
Just as I listen to this, it makes me think of the Drexel alerts on our cell phones. So even though our elderly patients might not be tech savvy and be able to use a portal, virtually everybody has a cell phone. And so just the same way Drexel sends out alerts, I would imagine that that might be something that we could do as like a mass text of sorts or a mass alert, if there was, you know, something universal that we wanted to say to all of our patients.
Great idea.
And
Dr. Williard.
Just one more thing to sort of circle back to everything. So I think to your point about advocacy, Esther, into something that Dr. May said at the beginning, I do really envision this more as an advocacy project. I mean, we will do what we can for our patients, but like, I've always felt like good care should not come from extraordinary efforts of individuals. It should be like the systems should promote it. And I think if we can get telemedicine continue to be approved, that's like a big deal. And this is just another reason to advocate for that and for like the lovely future steps that Dr. Fitzpatrick had put in, like home health aides. Like basically right now, for someone to get that, you have to like testify that they are stuck in home and homebound. So this wouldn't apply. This would be like intermittently homebound. So like the policies have to change to allow for us to really take things to our patients and have greater access. So I think it's building an argument for those things, like, again, bigger than me, bigger than us in this project. But I think that really it's adding fuel to the fire that we need to shift the way we approach patient care.
And I think just the awareness of it for the office staff too, so that when they're taking the calls that people are canceling, they're not just saying, okay, thank you, goodbye, and then hanging up. Like making that next appointment, making sure they're getting it maybe within the next 7 days, or, you know, making sure that they can convert it to a televisit, or putting the provider in touch with and say, you know what, you might need to call this person back because they're not feeling well and they can't come in because of such and such. So just that awareness, I think that this study might bring is huge in making impacts for their health.
There was a question or comment in the chat room that I wanted to address from Cecilia, asking about, is there any coordination with clinical offices in the City of Public Health Department in these extreme heat and cold events? Are there linkages between the department and maybe community health workers who are already in the community and know who tends to need more guidance? What I would say is our research is really a data gathering and a needs assessment before we can, you know, so have we partnered or have we coordinated with the health department yet? Not yet. You know, this is really, again, laying the groundwork and gathering the data. for what we all kind of had, as Dr. Willard said, we all kind of had a sense or a gestalt about what was going on, but this is actually getting the numbers to use as our, you could say, ammunition to advocate, politically to be able to keep telemedicine and have it a covered service, and then to think about more community outreach and resources and funding for those resources.
Awesome. Dr. Hanno.
Yeah, I was just going to bring up again, kind of going away from what we're talking about in terms of how to solve issues, but on a macro level and talking about, morbidity and things. I remember back to when I was a pathology resident, and Dr. Haresh Mirchandani was the chief medical examiner in Philadelphia. And he actually got a lot of flack for starting to put extreme temperature on the death certificates. And Esther's nodding, maybe you remember. As a contributing cause of death. And that really drew attention to what was going on. It was really controversial. And, for pathology, we're often pointed to as an afterthought, but that was something he was doing that I think got some attention. And now if you search, literature, there's, stratification of how often it is showing up on death certificates and, just as a public health measure. So I just thought that was kind of neat. I remember the scandal at the time, how dare he put that on there?
Very interesting. Thank you. Danuta?
Yeah, I think to go back to Janet's comment, you're looking at this as a data gathering to get political ammunition for action. I might suggest that since you're approaching it from a certain element of the systematic inquiry as research and not just a service assessment or a service quality kind of assessment, what is your particular practice doing, to really take time and bring to this, to your problem, what is already known about this. I think if indeed nobody else has addressed this question and there isn't any other research and any other data, then you've got a good pitch for going and get a really good grant, because you're showing that it's, to really, really address this and look at it. But my guess is, and you all came up through the education process to know that you can do a lot of systematic reviews and you can do a lot of examination of what's published as well as what's coming out in different other trials and clinical settings, and really see how big a problem is this. It's a very nice combination of thinking about what's happening with our climate, but how is that going to affect practice and how to get people to come to practice as opposed to other alternatives then that you would test. Will they come to a teleconference? And then what are all the reasons? It is a very complex problem, but part of doing research would be to sort that out, which I think would rather be sort of interesting. Get you a lot of graduate students paid if you get money to do that too.
There's a fair amount of data or research on gender and missing appointments. Kind of comparing, men tend to miss more appointments than women. And I believe that there's a little bit on age, but there really hasn't been that much that's touched upon climate that we've been able to find.
Ramesh.
So speaking of, that was going to be my next question, Janet, in terms of whether there's a gender difference, but sort of related to age, do you anticipate very similar issues when looking at pediatric primary care? I suspect your analysis have been on adults, right? If not.
We're all internists, so it's 18 and up. We did not look at the pediatric population.
Right. So is there any reason to suspect that the same issues are at play with the pediatric population?
Probably.
Yeah. Okay.
Yeah, especially since, I mean, if you think about it, those who are youngest and most vulnerable in that respect age group are dependent on an adult to bring them
Right,
in.
exactly.
And if
That's
they're
why.
not bringing themselves in, they're not going to bring the kids in either.
Right.
So,
But with that, you're pointing, here at Drexel, you've got, say, Chris is a very active and second good source in the art, which that would be a nice way of extending your interdisciplinariness and building community around what's already here at Drexel. I bet they'd have data about it, to also look at.
yeah, that's true. Well, thank you. This has been really engaging, and I appreciate all the comments, all the questions. Doug, you just put something in the chat. Do you want to say it?
Yeah, sure. Yeah, I mean, my comment was people who miss appointments are exposed to extreme temperatures, inhale hazardous levels of particles, get flooded, et cetera, have died and will continue to die at higher rates. If that's not a call to action, I don't know what is.
Yeah. I wanted you to say it because it's a perfect ending to exactly what we're concerned about. Thank you.
Well, thank you for that opportunity, and thank you for stimulating us in this direction that we must go in.
Yeah,
One
thank
more
you.
comment from Kami, and then I catch that one. Esther, you also had your hand up. Did you want to?
Yeah, I was just going to make a comment. So I've done some work for the health department in Philadelphia, particularly before I joined the Drexel faculty, and we still do a fair amount of work in the emergency preparedness world with the city health department. Janelle can describe this. She did her MPH with our group, but they're very interested, the emergency preparedness group, in working with primary care physicians. I think they recognize the important role that primary care docs play in people's lives. They're trusted sources. And so, there might be a way in which you could help them figure out how to reach out, because they haven't really been successful in terms of building bridges with the primary care world in Philly. And I think they feel like it's a missed opportunity. So maybe there's an opportunity there to connect and help figure out a way that they could leverage the communication capacity and impact of medical practices more effectively.
Thank you. So when you reach out to us to do more with Frontiers, you can guide us on how to make that connection.
That's fair. That's fair.
Well, let me thank you all for coming and participating in this lively conversation, and Nathalie and your team for stimulating it. Once again, that wraps up this year's ScholarSip. And if any of you have topics that you think might be of interest for our next year's themes or next year's directions to have speakers and people to gain conversation of interest to our community, to bring in more people from diverse backgrounds, please let us know. Stacy's always keeping a little file of those, and we actually go through various things to see what's happening. So this would be a help for us to do that. So thank you again. Let's give you a round of applause, all of you who helped us to do this.
Thank you.
And with that, let's do whatever you need to do to finish up, go to graduations, let's get this term completed with a bang. Thanks very much.